Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenters are Dr. Dale Amanda Tylor, Dr. Charan Singh, and Shelja Bansal. Dr. Dale Amanda Tylor was born in Montreal, Canada, and she resided there until completing medical school at the world-renowned School of Medicine at McGill University in 2002. She was then accepted into a general surgery internship and otolaryngology head and neck surgery residency at the University of Florida in Gainesville. She then elected to pursue further specialized fellowship training in pediatric otolaryngology head and neck surgery at Rady Children's Hospital in San Diego. She is currently board certified in otolaryngology head and neck surgery, both in the United States and Canada. Dr. Tylor currently practices medicine at Washington Township Medical Foundation in Fremont. Dr. Singh is a neurologist at Washington Hospital. She graduated from medical school at Lady Hardinge Medical College in India. She conducted her internship at Highland Hospital in Oakland and her residency and fellowship at Stanford University Medical Center. Dr. Singh is board certified in neurology. Shelja is a physical therapist with 5 years of experience in outpatient therapy. She completed her bachelor's degree in physical therapy from India and is currently pursuing her doctorate in physical therapy. She is a mother of 2 boys and in her spare time enjoys swimming, exercising, and doing activities with her family.
Why is this seminar so important? Why are you all here? Dizziness is a common problem. In fact, in a year's time, up to 10% of the population experiences some form of dizziness. And this goes up to about 40% of the population in individuals age 40 and over. In people age 65 and older with dizziness, a quarter of them can have a fall. This accounts for a lot of need of health care. The third most common symptom reported in elderly patients visiting their primary care doctors is that of dizziness. 1 of every 40 of all the patients in the emergency department have dizziness as the reason for them presenting to the emergency room in the first place. With that said, there are many causes of dizziness, which can be difficult to distinguish from one another. And there are no clinical guidelines in existence to guide physicians on how to manage dizziness as a medical problem. So that's an issue. You're not meant to read this, so don't worry. It's a slide taken from an online physical therapy presentation on dizziness, listing some of the most common causes of dizziness that we know of. The point's not to read it all, but to see that there's a plethora of reasons why someone might feel dizzy. So the plan for today will be first to discuss the basics of what is involved in balance and to distinguish between some terms that describe dizziness. I'll go into some of the ear-related causes of vertigo and dizziness, followed by Dr. Singh mentioning many of the other causes of vertigo and dizziness. And then Shelja will talk briefly about some of the treatments for patients that exist who have problems with dizziness and vertigo. Finally, we'll touch upon some patient scenarios that will help us put it all together. So how does this whole balance system work? Good balance depends on lots of different inputs from your body. It's very coordinated. You have your eyes or your visual system. Your vision helps you see where your body and your head are in relationship to the world around you and to sense motion between you and the environment. Muscles, tendons, and joints, which are called the proprioceptive system, They have special sensors in the muscles and tendons of joints that are sensitive to to stretch or to pressure. And these help your brain know how your feet and your legs are positioned compared to the ground, and how your head is positioned compared to your chest and your shoulders. The inner ear, near and dear to my heart as an ear, nose, and throat doctor, is part of the vestibular system. And so the balance organs in the inner ear tell the brain about movements and the position of your head. There are a set of 3 tubes or canals called the semicircular canals or balance canals that sense when you move your head around, and they help to keep your vision clear. There are 2 other structures for balance called the otoliths, also known as the utricle and the saccule. You won't be tested on this, so don't worry, you don't have to remember the names. But they help you sense your movement in a linear fashion, either up and down or forward and backwards. So they tell your brain the position of your head even when you're not moving. So putting it all together, all of these inputs go towards the brainstem. Information from your vision, your muscles, your tendons, your joints, the balance organs are all sent to the brainstem, and it gets this information, and from other parts of the brain it also gets information. These parts are called the cerebellum or the cerebral cortex. And this information from the rest of the brain helps you to understand how balance has been a factor in previous experiences in your life. So your memories are actually playing a part of a role of this as well. Your brain can control balance by using all this information and choosing which parts are most important for the given scenario that you're in. For example, in the dark, when information from your eyes is reduced or might not be accurate, your brain will know to use more information from your legs or from your inner ear. Or if you're walking on a sandy beach during the day, the information coming from your legs and feet will be less reliable. And so your brain will use information from your visual system or from your vestibular system. So once you have all of these inputs coming in and decisions being made in the brain about what to do with it, the brain will send information to your eyes and other parts of your body so that you move in such a way that it will help you keep your balance and have clear vision while you're moving. When there's a discrepancy with any of the visual, proprioceptive, vestibular systems or the brain, it can cause dizziness or problems with balance. So it's our job to try to figure out what's causing this problem so that we can help fix it. So I know all I told you was kind of a bit of a mumbo jumbo, and I tried to get a video that would help show you what I was talking about in a little bit more clear terms. The best one I could find was an Australian video from a physiotherapist, but I think it kind of will drive home a little bit all the different systems that are involved in understanding balance.
You've been balancing since before you were 6 months old, but you probably don't know how you've been doing it. Whether you're standing still or you're moving around, you keep your balance because your brain is constantly asking your body, where am I? Not just where am I located, but how am I positioned over my feet? No single part of the body can answer this question with 100% accuracy in all conditions. So the brain has to bring together multiple answers to form a picture of exactly how you're moving. So then it can tell your muscles exactly how to control that movement within the limits of your stability so that you don't fall over. When it just needs a straightforward answer, the brain tends to rely on your vision. It figures out where you are in relation to a reference point. If you know that the floor is horizontal and the wall and the door are vertical, you can see that you are parallel with that wall. You must be standing up straight. But when you have poor vision, like in the dark, or you start losing your eyesight with age, the brain has to pay more attention to the other systems in your body, like your inner ear. Basically, there are 3 ring-shaped tubes fixed in your inner ear that are filled with fluid. Floating in the fluid in each of those tubes is a bubble, and that works like a spirit level. When you tilt your head, the 3 tubes tilt with it, but the bubble stays centered in the fluid, so the fine little hairs that line the inner walls of those tubes move over the bubble as the tubes are moving, and from paying attention to which hairs are touched, the brain can tell precisely how your head is moving. And if that is not impressive enough, the brain can ask your muscles, tendons, and ligaments how tight or how loose they feel, and this helps it to figure out the angle at each joint in your body. Here's an example. When you're leaning forwards, the brain should be able to tell exactly how far forwards you are by sensing the increased pressure on the skin under the balls of your feet and asking the Achilles tendon precisely how stretched it feels at that moment. Ligaments in the feet will say if they're tight or loose too, and that all gives the brain a pretty good idea of how you're positioned over your feet. So all of this information is being sent in a continuous stream, and it changes constantly as you're moving. Knowing what information to request from the body, interpreting it, integrating it, and then responding to it quickly is a really complex job for your brain. But we don't tend to lose our balance when we're looking where we're going and focusing on where we're stepping. It's when you're weaving through the aisles of a busy supermarket and you see that a 2-kilogram bag of potatoes is on special for $3.50. You have to start calculating how much that works out to be per kilo in your head. And while you're doing that, you have to veer your path to allow another person's trolley to pass you. At moments like that, you're more vulnerable to losing your balance and falling over.
But it was showing how your eyes need to play a role, how your muscles need to play a role, how your spine needs to play a role, how your brain needs to play a role, and your ears, and how if there's problems with any one thing, it can affect the other. So, lots of people say they're dizzy, or they say they have vertigo, or they say they are lightheaded, but they don't all mean the same thing. And so I want to try to tell you how the doctors think of dizziness and divide the words up and describe the words so that maybe it'll be a little bit more clear for you. There are 4 main types of dizziness that we describe in medicine to help understand what's going on. Vertigo is the perception of motion when there's not actually movement going on. And this can either be in a linear or straight way where you feel like you're moving, but again, you're not actually moving, or in a rotating type of way. Often the classical, you feel like you're spinning around. And if you don't know what this feels like, I don't know if you can remember as a child turning and turning and turning around in a circle and then stopping, and then things just keep seeming to go around you. It can be quite disconcerting if you're not spinning around first and trying to make yourself feel that way. There's a non-specific description for dizziness that is not vertigo. You don't feel like you're moving, but you can feel lightheaded or foggy or a floating sensation or swimming or feeling off balance or confused. Going back to vertigo, that's usually coming from the vestibular system, and often the inner ear plays a role of that. But with the more non-specific kind of dizziness, it's not really so much the ear that causes those types of complaints. These are more visual, or that proprioceptive system with the muscles and the tendons and your joints. And it can be psychogenic. So if anyone knows people or themselves are prone to anxiety and panic, it's very common if you're breathing too quickly or if you're feeling nervous to have a sense of dizziness going along with that. It doesn't mean you're crazy. It's a very common thing to experience if you're having anxiety, but that's a really common cause of dizziness that we see. Disequilibrium is a sense of impaired balance and your kind of gaze not matching where your balance is. It sometimes can feel like you're falling or unstable, and that can come from parts of the spinal column, peripheral or nerves, say of the feet, or problems inside the brain or cerebellum, which is one of the centers of the brain that helps with balance. Finally, there's the term pre-syncope, which sort of feels like you're about to faint. And sometimes people describe seeing black spots out there. And often that's related to the cardiovascular system, such as if your blood pressure is too low, you may feel kind of woozy when you try to get up. About 40% of dizzy patients have peripheral vestibular dysfunction, meaning about 40% of the time, dizziness is coming from the ear. 10% of the time, it's coming from a central brainstem vestibular lesion. So somewhere in the brain, there's a problem. 15% have a psychiatric disorder of some sort, and that can just be as simple as having anxiety. and 25% have other problems on that really long list, such as presyncope or other causes of disequilibrium. So this picture shows the overlap between some of these terms that we use to describe dizziness. One thing is for sure is that it can be tricky to get to the bottom of why someone might be dizzy, and that's why we often order a lot of tests to try to figure out exactly what's going on. It's crucial for us to understand how long the episodes of dizziness last. And sometimes it can be frustrating as a patient when you go and the doctor keeps peppering you with what seems to be the same question again and again, but they're looking for certain answers that really help to distinguish what kind of dizziness is going on. Not uncommonly, a patient will say, "I was dizzy for the entire week." But really, when you get down to it, and you ask if you were consistently dizzy the whole time, or if it was just little bouts of dizziness going on multiple times a day through that time, you can tease out what's going on. For instance, dizziness that occurs for less than a minute at a time often comes from the vestibular system or from the ear, and is something called benign paroxysmal positional vertigo, which we'll talk about in detail in just a moment. When it lasts minutes to hours, it can be other things like Meniere's disease, issues with not getting enough blood to the brain, migraine problems, some psychiatric problems, and even things like syphilis that you don't even think about can cause that kind of problem. When dizziness lasts hours to days at a time, that can also come from migraine or Meniere's, and it also can come from various inflammation of other parts of the inner ear, such as something called labyrinthitis or vestibular neuritis. We like to know if the onset of the dizziness came all of a sudden or if it kind of gradually built up. That helps us to understand some of what's going on. And again, like we mentioned, whether it was a constant nonstop dizziness or if it was sort of on and off, and if you were perfectly still, you could get it to stop for just a little bit till you moved again. There are other important clues that help us to figure out what the underlying cause of dizziness in patients is. Changes in position, pressure, or loud noises can indicate an inner ear issue. Head injury can cause problems with the ear or the brain. Medicines can have side effects, especially when you're on many kinds of medicines for issues like diabetes, blood pressure, or pain. Alcohol can significantly impair balance. Foods can even cause issues if they trigger headaches or other types of problems. Stress just makes everything worse. We want to know if there are associated issues with hearing or noises in the ears or pressure sensation in the ears, and very commonly we'll get hearing tests for patients who have dizziness to help us understand this. Headaches, especially migraine, are commonly associated with dizziness. Nausea can be a clue to what's going on. Neck pain can give us information. Issues of associated weakness or numbness or blurred vision or slurred speech make us very concerned about possible serious issues with the brain, such as stroke. And panic or anxiety, fast or irregular heart rhythms, or fast breathing can indicate that the underlying problem is anxiety. Finally, it can be helpful to know what makes you feel better when there's a spell of dizziness, such as sitting quietly or going to sleep, and what makes it worse, such as movement, bright lights, or other types of things like that. Going into some of the major causes of vertigo and dizziness of an ear-related nature. So, big word, benign paroxysmal positional vertigo. We'll shorten it to BPPV for obvious reasons. What do those words mean? Those are pretty medical words. So benign means not life-threatening. Paroxysmal means it comes in a sudden, brief spell. Positional means that it gets triggered by certain head movements or positions. And we already know that vertigo means a false sense of motion. About 2.4% of people will experience BPPV at some point, and it's the cause of about 20% of all dizziness. And up to 50% of the time it's the problem when the elderly have the vertigo problem. What happens is that crystals can form in one part of the inner ear called the utricle, which sits right over here, and then that sits kind of next to these balance canals here. And there are no crystals that are supposed to be in these balance canals. So when these crystals form, they can break off and head into one of the balance canals. The balance canals don't usually respond to gravity. That's not their job. That's the otolith's job, the saccule and utricle. So when you have these crystals moving in, they will kind of move with gravity, and as a result, false information is being sent from one of these particular balance canals of 3 on that side and 3 on the other side. And because they're getting different inputs from the 2 different parts of the brain doesn't know what to do with that, and it makes you feel extremely dizzy. Patients will have repeated cycles of short episodes of vertigo lasting seconds to just over a minute that recur with certain head motions. Usually rolling over in bed, getting out of bed, and looking up can be head movements that cause this problem. So how do you treat benign positional vertigo? You probably all know someone that's had this problem before. Very often, patients are given this particular medicine called meclizine, or they call it bonine or dramamine. There's different names for it. And it can give short-term relief to some. But actually, there's not a lot of evidence to support giving this. And that's because the problem is related to these errant crystals. And treatment is designed at getting the crystals out of the balance canals to fix the problem. One maneuver that's used for the most common location and type of this benign positional vertigo is called the Epley maneuver. This helps the crystals shift back to the place where they don't cause trouble. After the maneuver, often you'll be asked to sleep semi-recumbent, or not lying straight down and not bending your head over too much for a couple of days, and that's to try to help the crystals stay out of the ear canals. And then you may be recommended to do some home exercises, something called Brandt-Daroff exercises, to help you recover. There's a newer, popular type of home exercise that you can do that's been described by an ear doctor that ended up getting dizziness herself. So she invented this other way, which helps some people, and that's called the half somersault maneuver. But luckily, you don't have to do a full somersault to do that. And these are all things that you can do at home. And there's lots of videos on the internet that show you how to do that. But it's usually a pretty good idea to know first from a doctor what's really going on before you try to start some of these, because they can make you feel pretty sick. With these types of treatments, over 90% of people can improve relatively quickly. Unfortunately, benign positional vertigo can reoccur periodically. And the long-term recurrence rates are as high as 50% within 5 years, especially in those in whom the benign positional vertigo is related to trauma. So a bump on the head can kind of shake up some of those crystals, and people who have it coming from that way are more likely to have it come back. So this video is going to show you how we diagnose the problem by performing something called the Dix-Hallpike test. The patient is being leaned back, and we'll watch their eyes in our clinic. We have a special kind of chair that lets you lean back all the way. And if this is the problem, it will make you feel incredibly dizzy. So that particular patient did not have the problem in the left ear. Now he's turning to his right side, and he is feeling super dizzy. So we know, oh my goodness, the benign positional vertigo exists on this right side. So we wait for a little bit to try to get the crystals into the right spot, and we start the therapeutic maneuver called the Epley maneuver by rolling the patient's head to the other ear. And this time it's going to make you feel dizzy on that ear because it's starting to shift those crystals around in the balance canals. We wait a little bit of time, and then we have the patient continue to roll a little bit more to try to keep those crystals rolling around the canal and going into the utricle. And then we'll sit the patient up. And sometimes we'll repeat that and do that twice. But if we repeat it, the second time usually feels a lot better than the first. So it's pretty gratifying because patients may feel better the same day or within a couple of days afterwards. It's possible to have inflammation or infection of the actual balance nerve, which is called vestibular neuritis. This inflammation disrupts the transmission of sensory information from the ear to the brain. This is the hearing part of the ear and the balance part of the ear, and there are nerves that go to each of those. And so if you have actual swelling of that nerve, it's usually just of the balance nerve itself. That can cause a fairly significant dizziness. Patients will typically have a fairly sudden onset of severe vertigo or dizziness that continues for days without stopping. It can be extremely scary, and many patients will go to the emergency room for this kind of problem. When hearing is impacted at the same time as dizziness, this indicates that the problem involves the labyrinth. So the labyrinth is the term for the fluid-filled portion of both the hearing and balance parts of the inner ear, the fluid itself can become inflamed. And so the difference is, in that case, you have not just the dizziness problem, but you also have a hearing problem. Usually it's a virus that causes this problem, and it's treated with steroid medicine to help treat the swelling, medicines that can suppress the terrible dizziness that you have, and possibly some antiviral medicine. Sometimes the infections can come from other places, like the middle ear, where a lot of children may have infections, or sometimes rarely you'd have an ear infection, or from the brain. It actually can come from a brain infection like a meningitis and come down through the labyrinth to infect the ear that way. After a period of gradual recovery that may last several weeks, some people are totally free of symptoms and they completely recover. Others can have chronic dizziness after this type of situation, however. They can find it difficult to work because of a persistent feeling of disorientation or haziness, as well as difficulty with concentration or thinking. Vestibular or balance therapy, which we'll hear a little bit more about shortly, may be indicated if there's ongoing dizziness in patients with this kind of problem. So Meniere's disease is a disorder of the inner ear that causes severe dizziness or vertigo, ringing in the ears or tinnitus, hearing loss, and a feeling of fullness or congestion in the ear. People who have this problem usually is only in one ear, although it could be in both. And the attacks of dizziness or vertigo may come on suddenly or after short periods of tinnitus or the ringing ears or muffled hearing. Some people will have just a single attack of the dizziness, separated by long periods of time. Others may have many attacks closer together over a number of days, and this can be really disconcerting. Meniere's disease can develop at any time, but it's more likely to happen to adults between 40 and 60 years of age. It's estimated that there are 615,000 patients in the United States that are diagnosed with this problem, and about 45,000 new cases a year are found. With Meniere's disease, the endolymph, or some of this fluid that's inside the labyrinth, will build up. And so it's almost like you have high blood pressure inside your ear, so high pressure inside your ear itself. What happens is this pressure buildup will interfere with normal balance and hearing signals between the inner ear and the brain. This abnormality causes the vertigo and the other symptoms of Meniere's that we talked about. Some researchers think that it comes from the constriction of blood vessels, similar to what causes migraines in the brain. Others think that it could be from viral infections, from allergies, from autoimmune reactions. Usually when there's researchers thinking all these kinds of things, we don't really know. Because it appears to run in families, it also could be the result of some genetic variation. It does not have a cure yet, but your doctor may recommend some treatments to help it feel better. Medications can be used to stop the dizziness when there's an acute flare. Restricting salt is a big one because, like I said, it's increased pressure, and so we'll actually sometimes restrict salt or give actual water pills to help with this problem to decrease some of the pressure inside the ear and some of the problems and some of these flares. Sometimes other dietary and behavioral changes may be needed. For some people, there's triggers of caffeine or chocolate or alcohol, all the things that are sort of really great in life. They can make it worse. And so we don't relish telling people to avoid all these things, but sometimes that really does help make it feel better. Not smoking also can help with this too. Sometimes things like cognitive therapy can be used in kind of talking over some of the feelings associated with the dizziness. We used to use some injections of some pretty terrible antibiotics to purposefully kill off part of the balance part of the ear that was causing these flare-ups. But now we'll use steroid medicine, so anti-inflammatory medicines that are injected through your eardrum to try and touch your inner ear a little bit easier during flares, and that can really help as well. Finally, there's some pressure treatments that can be utilized. We can put a little ear tube in the ear, and there's some devices that actually will push pressure into the ear, and oddly enough, that seems to help relieve some of these flares of Meniere's. And in very rare situations, we have to do actual surgery to decompress the ear. It's not unusual for patients to feel that their balance can be sometimes impacted with a bad cold. This can come from fluid in the middle ear space, which is adjacent to the inner ear. Severe ear infections, or ones that involve the mastoid portion of the ear apparatus right behind your ear, can cause labyrinthitis, as we discussed before. Cholesteatoma, or skin that's gotten into the middle ear, usually from chronic ear problems or from a hole in the eardrum that's been there a long time, can erode into the inner ear or intracranial cavity, causing dizziness. And if they use station tube, or the natural pressure equalization tube of the body that equalizes the pressure from the middle ear here to the top part of the back of the throat, is not working, particularly around times of allergies or with colds, it causes problems as well. The one thing that ear, nose, and throat doctors are often really worried about is missing the big things. Along the balance nerve, you can get a benign tumor that can grow and can pinch off the nerve, either the balance nerve or the hearing nerve or both, and that can cause a problem. So we're always thinking about this problem because we don't want to miss it. So acoustic neuromas, also known as vestibular schwannomas, are a rare benign tumor of balance and hearing nerves. About 95% of the time, they're only on one side, and they don't tend to spread or anything like that. And there's about 2,000 or 3,000 new cases of this problem found every year. And we find them in Fremont several times a year. It accounts for about 7.5% of all brain tumors. They grow very slowly, although some can grow faster than others. And initial symptoms can include single-sided hearing loss, balance disturbances, vertigo, ringing ears, or fullness in the ear. If they become really large, they can push on the brain and cause other types of issues too, and neurological function problems. And to treat this, you may just observe it. They may grow so slowly that you just repeat MRI tests to be sure it's not growing well. But if they're causing symptoms, options can include removing it with surgery or giving very rare doses of radiation to just try and stunt it and prevent it from growing any further. This is another mouthful, superior semicircular canal dehiscence. So the balance canals of the inner ear are all encased in bone, except in 1 to 2% of the population, the top part of the top balance canal, the superior semicircular canal, can have a dehiscence, or basically some of the bone is missing. And that means that the brain can just kind of sit on it and push on it, and the pressure from inside the head can be transmitted to that particular area. It was first described in 1998, so it's fairly newly described. And patients who have this problem can experience vertigo and oscillopsia. And so the term oscillopsia means the apparent motion of objects that are known to be stationary. So things really seem to be moving. You don't seem to be moving, things seem to be moving in that case. And that actually can happen just from hearing a loud noise, because you hear the loud noise, boom, it changes the pressure and that can hear it. Or just changing the pressure, even if you sneeze or cough or bear down to go to the restroom. Also, you may hear your voice too loud in your head if you have this problem. Sounds can just seem too loud, and there may be some kinds of unusual hearing loss, like a bone, seeming like a bone-like hearing loss, even though it's involving the inner ear, which usually would be a nerve-like hearing loss. Some patients have more balance-related symptoms, some have hearing-related symptoms. It sort of depends. The interesting thing is 1 to 2% of all people have this thinning of the bone, but it's not 1 to 2% of people that have this problem. It's just a rare subset of people that have this problem. So in many cases, it's just something that's found on a scan and there's nothing to do about it. But if you have dizziness, there's the option to consider surgery that actually will give you a new bony separation between these balance canals and the brain itself. Ototoxicity. So oto kind of means ear, and toxicity means poison. So essentially, you can be poisoned by the medications you take or chemicals in the environment. The ear is involved in, as we know, hearing and balance, and various medicines may affect one or both of these conditions. It may be temporary, like for example, aspirin, if you take high doses, is known to cause a lot of ringing, but generally that doesn't cause a permanent kind of hearing loss. Or it can be more permanent, as with certain antibiotics can cause this problem, or chemotherapy agents. So if you know people who have been getting chemotherapy, some of them that are known to cause hearing loss, they'll get repeated hearing checks during the therapy to see if that's happening, and we try to prevent it with certain injections if so. No one knows how many people suffer from this problem every year or what percentage of balance disorders are caused by this, but there are a lot of medicines that can cause trouble. It's important to know that there's no drug that's been found to cause things like Meniere's, benign positional vertigo, or other vestibular disorders that are causing fluctuating function. So those don't seem to be the cause. Stopping any of those medicines don't seem to change these positional type problems. Right now we don't have any way to reverse the problem, so it's mostly a question of trying to rehabilitate if the hearing is lost, to use hearing aids or consider things like cochlear implants, surgery to try and fix this problem, and then balance-related therapy if there's certain balance dysfunction. Unfortunately, we can't change that as we get older, there are changes in the inner ear. Add that to changes in other parts of the body that are involved in balance, like the eyes with cataracts, or the feet with diabetic type changes, or stiffness in the joints from arthritis. And it can spell real balance problems as we age. In the ear, nerve cells start to diminish after age 55. Blood flow to the inner ear also declines as we get older. It may not always cause abrupt dizziness because it can happen so slowly that you might just get the balance problems alone just because things aren't working as well as they once did. It's important to remember that methods to prevent decline, like eating well, walking or exercising, and using Tai Chi can be a great thing to do. Sometimes some physical therapy for conditioning the muscles can help, or the balance therapy like we talked about. It's really a question of figuring out what is wrong so it can be treated properly. And with that, I'm going to turn it over to Dr. Singh.
Good afternoon, everybody. And I would like to echo Dr. Tylor's sentiment. Thank you all for coming. It's great to see a full house and more. When I was invited to give this talk, I actually found the idea to be very nice to have an ENT specialist, a neurologist, and a physical therapist to give a talk about dizziness. That just goes to show that dizziness has so many causes that you really need a team of people to sometimes come up with the reason. Also, dizziness might change from one particular episode to another. For example, as Dr. Tylor talked about, you could have things like benign positional vertigo or Meniere's, but at another time your blood pressure medicines may be too high. At a different time, your sugars may be out of whack. At a different time, you may have things like, well, I hope not, but TIAs or strokes. So it's an evolving process. Just as our body keeps changing, the reasons for dizziness can also be disparate. So a lot of times, Dr. Tylor will send me patients whom she's ruled out the ENT causes of, and vice versa, that I don't find anything that's neurological and I refer for an ENT evaluation or physical therapy evaluation. I just wanted to talk about the causes of dizziness being so disparate. You already saw Dr. Tylor's slide that had so many causes. But we like to think of the more common causes. For example, I might think about somebody based on their age, the causes of dizziness may change. For example, migraine that Dr. Tylor alluded to, migraine-associated vestibulitis, or migraine-associated dizziness, for example. Concussion, she talked about, how the crystals in the utricle can be sort of displaced into the semicircular canals. Then cervicogenic dizziness, I don't think there's any of us that doesn't have any kind of neck tightness. It just goes with the territory of being upright, of sitting for long times, of sitting in different positions, bad postures. Even if you have a good posture, you may still have degenerative changes based on your age, your genetics, your exercises, your general physical health. So it could come from the neck area, called cervicogenic dizziness. Then, of course, she sort of alluded to the age-related changes that we all go through as we get older. And I will talk a little bit more about it from the brain and the neurology perspective. Then, of course, we have disorders or diseases like Parkinson's disease, like multiple sclerosis, like strokes, like neuropathy from diabetes, like other such chronic conditions that give rise to dizziness. She also alluded to tumors that are benign, that are slow growing, acoustic neuromas, schwannomas, cholesteatomas. She also talked about vestibular neuronitis or labyrinthitis. And then there's this combination syndrome of ataxia, which means there is imbalance because of the cerebellum. The cerebellum is a part of the brain that manages our coordination. And sometimes when you have problems there, you could have balance issues and dizziness. And if you compound that with neuropathy, where your feet are not feeling the sensations, the pressure receptors in your feet, the pressure receptors in your spinal cord are not working very well. And then you add that to the vestibular system not working very well because of aging. That's like a triple whammy right there. And then there's something called mal-debarquement, which is something that we don't usually see. It's mostly 75% of sailors see that, but a lot of us are taking cruises now. And sometimes at the end of a cruise or a long airplane ride, you know, a lot of people are going to 17 to 20-hour flights. When you get off, you have the sensation of movement, of being on the ship or the airplane. That lasts a bit longer, maybe 24 hours, maybe 48 hours. But in rare cases, it can happen a few months later. You're still sort of feeling that little imbalance. The longest cases have been as long as a year, unfortunately, but that can also be seen. So, you know, these are the different causes that I get to see from the neurological perspective. Busy slide, but I just wanted to tell you that migraine, about 40% or so, 25 to 40% of migraineurs may have dizziness at some point during their migraine, known as migraine-associated vertigo or migraine-associated vestibulitis. So what's the difference? Well, obviously the headache, that's a pretty big difference. But headache with vertigo can be seen even otherwise, because when your body is, quote, out of whack, you know, headache is a pretty common symptom. But when you have headache associated with nausea, with light sensitivity, with a feeling of sounds kind of irritating you, you want to go lie down in a dark, quiet room, you don't want anybody to talk to you, you don't want any noises, you want to be left alone, maybe with an ice pack on your head, that sounds like a migraine. And along with that, sometimes people have dizziness. And so that's the migraine-associated vestibulitis. And add to that some neck tightness that occurs because, you know, a lot of us have a tendency to tighten our necks at times when we're stressed. And so that adds to the cervicalgia, cervical cause, the neck cause of dizziness. So migraine-associated dizziness can happen. In some severe cases of migraine, and also when you have associated dizziness, you may actually have some confusion. It's that feeling of not being well, not wanting to think, that same leave me alone. And that can also occur, and you may not want to speak, or you may have slurred speech. That may be a migraine, but as we get older, that could be a sign of a stroke. So something that we should educate ourselves, and if we think we're having a TIA or a stroke, the best thing is to go to the emergency room, because you want to get it checked out. Also, sometimes, even after the migraine has, you know, stopped with your regular medicines, you may still continue to have attacks of either just an ongoing dizziness or paroxysmal attacks of BPPV that Dr. Tylor talked about. So this is another busy slide, and this is talking about the cervicogenic causes of dizziness. Pretty much causes because of cervical spondylosis or changes of arthritis in the neck. Arthritis being changes in the bone, changes in the joints, the facet joints, thickening of the ligaments that go down the entire vertebral column that sort of keeps everything in place. So there is no specific test, but a lot of times cervicogenic dizziness adds to the other things that are going on causing the dizziness or headaches. And basically, it is associated with neck pain, but the dizziness can continue even after the neck pain abates. And you can see it after concussions or whiplash injuries, like you have a rear ending, the dizziness may continue, or the neck tightness may continue, or both may continue. Dizziness may add on to the neck tightness, so sort of like a vicious cycle that can happen. And the dizziness will be helped if you treat the neck and the dizziness. So decrease the muscle tightness, the muscle spasm of the neck, and maybe do the vestibular therapy that you'll hear about. So it's always a multi-pronged approach. You have to take the multi-pronged approach to help you with these different issues, the muscle tightness, the dizziness, that seem to go together. Usually if you treat both, prognosis is pretty good. 75% of the people do get relief. And if they don't, then, you know, there are other things to give. And also to add on, you know, muscle relaxants can be given for the muscle stiffness, but muscle relaxants can have dizziness as a side effect. If you look at all the medicines, you look through all the side effects, pretty much all of them say dizziness pretty high up in the medication list. Age-related dizziness. Dr. Tylor alluded to some of the age-related changes that can happen. You know, the vestibular system ages. There are arterial changes in the labyrinthine and vestibular arteries. There are changes of degeneration in the semicircular canals that can happen. And when you add all of that together with, say, sedentary lifestyle, pelvic deconditioning, which is when you sit for long periods of time, you have weakness in the proximal parts of your legs and your pelvic muscles, the glutei, the buttocks, etc., you're set up for falls. And 20 to 40%, unfortunately, adults who are over 65 fall in their house. That's a pretty big number, I'd say, 20 to 40%. Wow. And then if you have a hip fracture, your mortality can increase. So as Dr. Tylor alluded to, there are different areas that coordinate the balance, the way we walk, which includes your nerves, your pressure receptors, your vision, your hearing, your balance, your vestibular system, and your cerebellar system, which is your brain. And all of them come together, and you know, if there are degenerative changes in any of these systems, obviously there is a higher likelihood of one becoming dizzy or unbalanced. You can be unbalanced even without being dizzy, that unsteadiness when you walk, because your feet don't feel the ground, your pressure receptors are not doing the great job they're supposed to. Your spinal nerves are kind of a little bit off, not quite doing what they're supposed to. And, you know, you're set up for falls, with or without dizziness. Just wanted to mention in the central nervous system, the CNS causes of dizziness, strokes. I'll show you a couple of cases, maybe of stroke, which sounded like stroke, but were not, which sounded like vestibulitis, but were strokes. So we get confused all the time because symptoms are quite similar in all these, because it's the human being, right? A human being can have different kinds of symptoms at different kinds of times. Parkinson's disease, one of the things in that is autonomic instability, where your autonomic nervous system that manages your blood pressure, that manages to keep your blood pressure from plummeting down when you stand up. That is called the autonomic nervous system. That gets affected in Parkinson's disease, as well as there's something known as postural instability, which is part of the cardinal feature, where your center of gravity is a little bit off. That can be seen in Parkinson's disease. That can lead to imbalance with or without dizziness, causing falls. Your autonomic nervous system can also be affected in disorders like diabetes, when you have not only the neuropathy because of lack of sensory input, the sensory nerves, but also the autonomic nerves are affected. So your blood doesn't go right up to the brain as it's supposed to when you stand. So what happens is when we stand from a sitting position, the veins actually get milked up by our muscles. So firstly, the blood doesn't all pool to our feet. Secondly, it sort of gets enough anti-gravity momentum so it reaches the brain. If the blood doesn't reach the brain, or there's reduced blood to the brain, you kind of you fall because of dizziness. And so the autonomic nervous system is supposed to do that, help with that milking up. Then you can have NPH. NPH is normal pressure hydrocephalus, one of the things we see in an aging brain, where you have increased water on the brain. Hydro is water, cephalus is brain. It's different from just hydrocephalus in that the pressure is not much. And so you really don't have headaches. You don't have really any other symptoms, but you could slowly develop a triad, 3-symptom complex of dementia, which is memory issues. You don't remember quite as much. Urinary incontinence, where you're losing your urine more and more, and balance problems, gait instability. The way this is diagnosed is if somebody comes and, you know, you might come in and say, you know, doc, I'm not really remembering as much as possible. Now, all memory changes are not NPH. All memory changes are not Alzheimer's. They can be age-related. But you see this combination effect of urinary incontinence, of gait instability, of memory problems. That could be normal pressure hydrocephalus. And it is diagnosed with a CT, where the ventricles within the brain are much larger than they should be. And sometimes, if it's bad enough and symptomatic enough, we can actually shunt it. You put a ventricular peritoneal shunt. Put a shunt in the ventricle, under the skin, you thread it down into the abdominal cavity, so gravity helps you shunt out that extra fluid. The fluid is the same that you normally have, cerebrospinal fluid. Normally, there is a good cycle of absorption and production. There is the same amount of production as absorption, so it's constantly being cycled. But if something goes wrong with the absorption, then you have increased water in the ventricles. That's called normal pressure hydrocephalus. TBI, traumatic brain injury. Traumatic brain injury or concussion that can happen can be up to 3 months or 6 months, the symptoms, where your brain gets rattled within your skull. So the skull is this hard thing, and the brain is rattling like jello inside. So you may not have any overt damage. Like if I were to do an MRI, I may see nothing. But there's something called diffuse axonal injury, where the axons, which are the nerve fibers, kind of get stretched. And that stretching can lead to a lot of things, including dizziness, including headaches, including focus problems. So traumatic brain injury can cause dizziness as well. Then, of course, we all know high blood pressure, low blood pressure with medications. When you have too much blood pressure, sometimes you feel that sense of fullness and dizziness and imbalance. Sometimes when your blood pressure goes down too low because it doesn't reach the brain enough, you have the same feeling of dizziness. High glucose, low glucose, because our brains are exquisitely sensitive to glucose. Basically, the food for our brains is oxygen and glucose. That's what they eat. So and it has to be concurrently, ongoing, presented to the brain, which is why when there is a blockage in one of the arteries, the area of the brain dies because it's not getting it. The brain doesn't store this stuff. You have to keep providing it. So when you have low blood pressure, or if the sugar is not enough, you could get dizzy. And of course, autonomic neuropathy that I kind of alluded to, and infections. Anxiety attacks, Dr. Tylor talked about. You overbreathe, the oxygen goes out. The carbon dioxide reduces in the brain. The brain always needs homeostasis, balance. Balance between carbon dioxide and oxygen. If you're overbreathing, you're blowing out the carbon dioxide. The balance is off, you get dizzy. That's what causes the hyperventilation-induced dizziness, which is why a lot of times when we are stressed, we feel dizzy, because without realizing we're having shallow breaths. So you're blowing out the carbon dioxide more than you should. And then, of course, anemia. Sometimes when there's low hemoglobin, there's not enough oxygen that's going to the brain, because hemoglobin is carrying the oxygen to the brain. So you feel dizzy. Poorly balanced diet, which could include vitamin deficiencies. Vitamin B12 and other B-complex vitamins are very important for the spinal cord and all our nerves. So when those are in deficit, you have deficiencies. You can have dizziness because your sensory system is not working as well. Your nerves are not being given enough nutrition. And of course, medicines. We all know all medicines can cause dizziness, either in normal doses or high doses, too much, too little. Vertebrobasilar insufficiency. What is that? Vertebrobasilar system is the system in the back of the head of the blood vessels. There are blood vessels, the main 2 blood vessels going to the brain. There are 2 sets. There's carotids that supply 2/3 of the brain, that go straight from the aorta into the brain. Again, from the aorta in the back, we have the vertebral arteries that go up. These vertebral arteries go through the neck area, in between the vertebrae, and then they join to form the basilar artery. And then the basilar artery divides into the posterior cerebellar artery. So that's how the brain is supplied, from the anterior and the posterior circulation. Sometimes, if we smoke a lot, if we have accelerated atherosclerosis or extra cholesterol, or we have other problems causing hardening of the arteries, the vertebrobasilar arteries could also get hardened, thickened, calcified, cholesterolified, if there is a word like that. And then you have less blood supply going to the important part of the brain, which is your posterior fossa, which is where you have your respiratory center, your cardiovascular center, basically the part that controls not the thinking part, but the part that controls every organ of your body. So when you have that, you could get dizzy because of that, and people could get strokes from that. The main thing about the stroke, which we all know, I am sure, in this room, is the acuteness of it. It just hits you. 1 minute you're fine, next minute you're not. That's basically a stroke because of lack of oxygen. So vertigo occurs suddenly without warning. You could have other symptoms. Not only can you have the vertigo or the dizziness, you could have vision problems, swallowing problems, speech problems, weakness problems, numbness. And so when you have a plethora of symptoms, then you're thinking it's probably more of a stroke rather than just vertigo. So I just got a couple of cases in the last 3 months that I had seen of dizziness in the hospital. You know, at 3 a.m. in the morning when the emergency room doctor calls me and says, oh, I have somebody who's had dizziness since 11 p.m. They're having nausea, vomiting. What do you think it is? I don't know. I mean, it could be vertigo, but what if it's more than that? So that's why we try and admit everybody that has any symptoms that started acutely or not, you know, has been going on, but the person has not improved, just to rule out a stroke. Because sometimes we can make a difference and we can prevent strokes from happening. And the other thing I wanted to point out was all these cases sound so similar. And I'll show you that each one of these cases had a stroke in a different part of the brain. And one didn't. But they all sounded so similar, it was hard to know without the further workup. So here's the 68-year-old male, and he has waxing and waning symptoms. He has had dizziness, nausea, vomiting on and off for a month. And then he started to get double vision, and that's when he got scared. Initially, he thought it was some kind of a GI disturbance, some stomach, intestinal problem. Then he thought it was an inner ear problem. But once he started getting double vision is when he got scared, rightly so. Went to the urgent care, and we admitted him. And I think you can see there's a tiny dot. It's hard to see. I'm sorry. I couldn't get a better picture of it. But I showed you 3 different areas of the same spot, which is showing medullary stroke. The medulla is in the back of the brain. In the bottom one here, you can actually see the shiny area. That is where the stroke occurred. This is also to point out that the stroke doesn't have to be large. It just has to be, if it's in the right area where all the nerve fibers come together, it's going to cause more damage. The same size in a different area, you wouldn't even know about. So that's the other thing. But anyway, this was in the right area for him to have the dizziness, nausea, vomiting, and then the double vision. This is a 78-year-old male, and he had 1 month-long dizziness and then double vision, headache, and generalized weakness. And here he has a different area of stroke. He has a cerebellar stroke, which is in the area of the balance, and also in the back of the head. That is an occipital stroke. That is in the back of the head, right over here, but it's in the top part, the cerebrum, the thinking part. And then we have the cerebellar stroke, which is right here. And that's the area of balance. So he had a bunch of strokes in multiple areas. We have a 58-year-old woman who had dizziness, spinning head sensation, and a sense of imbalance. And she had a completely different area of a stroke. This is over here. It's on the right side, but deep inside the brain here. Similar symptoms, but different area of a stroke. And then we have this 86-year-old woman who had the same new onset of dizziness, room spinning with head movement, nausea, vomiting, and right leg weakness. And she had no acute strokes. These are all old white matter that you see. These are all part of aging. There was no acute stroke, and she actually had BPPV, the benign positional paroxysmal vertigo. So it goes to show that, you know, sometimes we get frustrated when our doctors can't tell us, well, what's the cause of dizziness? Well, it's because there are so many causes that you really have to sit down and sort it out, and maybe sometimes you need different specialties to think about it in a different way. And then sometimes you can come up with the causes, and sometimes you can't. But anyway, that's what it is. And I just wanted to say, to prevent falls, basically good health, good nutrition, good physical condition. And in fact, some people actually say that everybody over the age of 50 should undergo balance exercises with therapists. They go as far as to say this, because as we get older, like I said, there's pelvic deconditioning from sitting too long. Our receptors need to be retrained. Our muscles, our joints need to be retrained. And regular exercise, walking, yoga, gait and balance training is helpful. And as we get older, we need to pay more attention to having good lighting, secure footing, and if we need any adaptive devices like handrails, anti-skid devices, to use them. Sometimes we get a little bit sensitive about maybe using a walker. I've seen some of my patients don't want to do that, and I totally understand that. You don't want to hit that button there, but sometimes it's a good idea to prevent falls, to take preemptive steps. So now we'll have Shelja come up here.
So we have a system of equilibrium. As Dr. Tylor talked about it a little bit, that equilibrium is a complex function that requires accurate information from several sensory modalities, including vestibular, visual, and somatosensory input. Dr. Tylor talked about the internal ear. We have semicircular ducts, anterior, lateral, and posterior. And she talked about the otolith organs that detect gravity and are sensitive to linear acceleration. We have the small and large protein calcium carbonate crystals that move and weight down the membrane as our head moves. Why this is so important? Because this causes, if these crystals, they come out of where they are positioned and they start to move in the semicircular canals, then we get the symptoms of dizziness. So how does physical therapy helps? So when patients with symptoms of vertigo and dizziness comes to our clinic, we take their complete history. Patients are examined with various tests that challenge their visual, vestibular, and somatosensory systems. Then if we found appropriate, clinical maneuvers are implemented to reduce the symptoms. Sometimes patients are also advised to do some exercises at the PT clinic and at home, depending upon the situation of the patient. So depending on the patient's symptoms and tests, if the primary cause of the vertigo seems to be otolith dysfunction, the canal repositioning maneuvers, which are called CRM techniques, are decided by the therapist and performed on the patient. Some of the treatment procedures used are Semont laboratory maneuvers, Apley's canalith repositioning, Gann's repositioning maneuver, Cassani and Appiani maneuver. So Dr. Tylor talked about Apley's canalith repositioning a little bit. So just to give you an idea, first the patient is seated, and if we think that it's the right ear is affected, the patient's head is rotated towards the right side 45 degrees, and he's laid down on his back with the head turned 45 degrees and extended a little bit. And this position is maintained for like 30 seconds to 1 minute. Then the patient's head is turned towards the left side, maintaining the extended position of the neck and turned 45 degrees. This position is also maintained for 30 seconds to a minute. And then the patient is helped to move towards the left side, like now the patient is in left side lying, if you can see in between the 4 and 5 position. And the head is positioned again 45 degrees, turned towards the left side. Then the patient is moved towards the sitting position, and then the head is tipped down so that there is the particles or the calcium carbonate crystals, they settle down to their correct position. So this maneuver is done like 3-4 times depending upon how the symptoms are. Sometimes just in a couple of sessions the patients are out of the symptoms, they don't have any dizziness or positional provoked dizziness, as they say, so they don't have to do it anymore. After this maneuver is performed, patients are told to keep their head in a vertical position. Then they are told to sleep in a semi-inclined position for 1 night at a 30-degree angle approximately. They are told to avoid sleeping on an involved side for 3 to 4 nights. However, these limitations are not given to all the patients. It depends upon what is the condition of the patient. If the symptoms are recurring in a patient over and over again, then we tell them all these limitations. Otherwise, we don't tell these limitations to the patients. Vestibulopathy, we call it unilateral vestibulopathy and bilateral vestibulopathy. This is assessed by symptoms and computerized visual acuity test, which is called VAT. Visual acuity test was developed by American Institute of Balance in 2000 and has reported to be highly sensitive indicator of unilateral and bilateral vestibulopathy. In this test, basically the patient sits at a distance of 2 meters from the computer screen and read 5 numbers of different font sizes in front of them. Patient read these numbers first with the head neutral and then with horizontal and vertical movements of the head. So the correct numbers are marked by the therapist on a form and scored later accordingly. So depending upon what the scores are, the therapist decides what kind of exercises can help the patient. So for vestibulopathy, 3 kinds of exercises we generally tell the patients. First is adaptation exercises, which is basically done with gaze stabilization exercises that uses the plasticity of the CNS to extinguish symptoms. We'll talk about the gaze stabilization exercises in the next slide. Habituation is a repetition of the provocative movements in a controlled manner that results in reduction of pathological response. The next is substitution, which is a strengthening of the weakened system to return to function by challenging the remaining ones, like doing legs and arm movements, sitting or standing on a foam or trampoline, etc. So the exercises for gaze stabilization basically is you're just going to have a fingertip in front of you like this, and you're looking at the top of the fingertip, and we tell the patient to keep looking at top of the fingertip and then start moving your head sideways like this. But don't just take off the gaze from the index finger. Just keep on looking at the fingertip and then just move your head. So this is like in a very slow manner. It's not like, very fast movements. So because if you have the vertigo symptoms, you might feel dizzy when you are, moving the head in a fast motion. So this is done like, 5 to 10 repetitions 2 times a day. The next one is moving your gaze from one point to another, keeping your head in place. Like you have these now 2 index finger of 2 hands, and then you keep your head stable and you keep on looking at the left index finger and right, left and right. So keep on changing the position of the eyes but not the head. So these kind of exercises give signals to the brain and kind of strengthen that system that this is normal. The eye movements are normal, the head movement is normal. So these are a couple of exercises I just talked to you about, and during my next seminar we'll talk more about the exercises that we do and how we figure out what the problem is and what are the maneuvers we do and everything, that how to prevent falls and everything else. This is our contact information, and I think I'm done.